Good morning, everyone. I'm Jacob with BHX, partner. Hi, Jordan. BHX is hosting the conference, and we're excited you're here. Thank you for attending. Hopefully, we'll provide you some more great information today on telehealth. So with me, I've got Riley and Michael, and I'll let them give their own introductions.
Go ahead.
Riley Osborne, Executive Vice President at Recovery Unplugged. We're an online and in-person substance abuse and mental health provider located in Florida, Texas, Tennessee, Virginia, and New Jersey. We believe that music is medicine. We use it as a catalyst for change.
Amen. Great.
Outstanding. Michael Castanon, CEO, founder of Ultra Health Group and Mindfully. We have a full ecosystem of care primarily focused around primary mental health. We do have SUD inpatient as well. Exciting sort of evolution is that during COVID, we were able to obtain a grant from FEMA to support the state of California to do virtual care for anyone in the state that was impacted emotionally or mentally because of the pandemic. And during that time, we had 35,000 encounters of care that we provided. So we learned a lot about telehealth and support. And we've also created some IP and science through research that we've been a part of. And we also have a privatized version of the virtual care platform called Mindfully.
Great. So just to get us started here, in case anyone in here, I don't know why they'd come in, but maybe they don't know anything about telehealth and virtual care yet. Maybe you can give us a quick overview. Riley.
Yeah, telehealth really is leveraging technology to bring healthcare access directly to a patient, no matter where they are. That's the simplest verbiage I can think to use.
Yeah, well said. I think it's an opportunity to create greater access and equity. We are dealing with this crisis of mental health, particularly in the adolescent and college-age population. We've all been reading about the data and the crisis. Many of us have children and kids who are impacted by it. But I think the opportunity should not just be looked at. There is the opportunity to extend the services that you provide traditionally inside of your brick and mortar through a virtual IOP or PHP, but it goes well beyond that because the government and other agencies are looking to support the well-being of society and the population. So we've been fortunate to sort of rethink how can you do that, and for the virtual platform just allows us to make it very easy for someone to reach out and get the care that they need, either in a crisis or just through their ongoing desire to be on a path of well-being.
So it sounds like you would see this service delivery model kind of changing the landscape, right, of behavioral health.
Well, we've experienced that. I can tell you right now, if I didn't, 5 years ago, if you had asked me, would 30% of our revenue and most of our care be delivered through the virtual platform, I would have said no way 5 years ago. I intended, as an organization, our strategy was to be primarily an inpatient, in-person, brick and mortar sort of provider. But if you've read some of the news about funding that's come through the governmental agencies, I would encourage you guys to rethink the way you're thinking about mental health, because we have been, as a for-profit, we're a multi-grant recipient. We've received over approaching $10 million in grant funding to provide care virtually. It's such a big issue in society. And so if you're thoughtful, if you're responsible, if you're purpose-driven, if you're mission-focused, and you're looking to really do greater good and have a greater impact, virtual care is a great solution. One last thing I'd like to say is that we all have admissions centers, call centers, what percentage of the folks that call and reach out for help are we actually able to support? I looked at the data, and it was anywhere between 3 and 4%. It fluctuated between that. So what happened to the 96% that reached out for help? What did we do for them? And that was the dilemma that I was trying to solve and address. And so through this virtual capability, we can do that.
That's interesting. Riley, do you have any experiences with, to that point, some previously unreachable populations and being able to now reach them, to serve them?
Yeah, absolutely. For us, COVID was a nightmare of a situation, but the large positive that came from that huge dynamic shift, in my opinion, is that it forced not only behavioral health care, but also just our world in general into the 21st, 22nd, 23rd century in a big way. And for us, our virtual program really was born out of a frustration for a lack of resources in rural areas. And so we would have people come to our inpatient facilities, do phenomenal, they're ready to get back to life, and then we send them to a town with 5,000 people in it, and no meetings, no support, no psychiatrist, nothing there. And then 3 weeks later, they're calling us because they need help again. And so as a way to bridge that gap for rural communities, working individuals, stay-at-home moms, any demographic that otherwise wouldn't have been able to access treatment, we put together this program that wasn't just, we didn't just throw it together. I wanted to be the antithesis to what you traditionally had seen from an IOP perspective, if you will. So in recovery myself, got sober at 19, and for me that looked like getting in my car, driving somewhere, sitting there for 3 hours, going home. Getting in my car, driving somewhere, being there for 3 hours, going home. Getting in my car, driving somewhere for 3 hours, going home, right? And so, but it all stopped there. Those 3 hours, that's all I got. And so I wanted to be able to engage patients not only more frequently, but on a daily basis. And so what we do with that is we have a model that's very similar to what we saw earlier from the managed care presentation, where you've got a case manager, you've got a nurse, you've got a medical provider, you've got an individual therapist, you've got an alumni coordinator, you've got a peer recovery support specialist. All these people are a part of your team. We're adding people to people's teams, right? And so what I've been able to see from that is, simplest story, I could tell you 50, but one of the coolest stories I experienced was we had a mother that had a 6-week-old child, and she came through Recovery Unplugged Nashville, and so there's a 6-week-old child. She had to come to treatment, didn't have a choice, right? Had to get better. She wanted to do it for her kid, for herself, and so she's in treatment. She's pumping while she's in treatment, and so she's planning on doing a month, maybe even 60 days of treatment, and then insurance says, actually, we don't think you meet criteria. Short-term disability ran out, FMLA ran out, and so it's like, okay, what do we do? Oh, then mom calls, and mom can't watch the kid anymore, right? So she's got all these nightmare scenarios coming online, and she was going back to a tiny town in northwest Tennessee, and we had our virtual program, and so she gets home. Kid's 8 weeks old at that point in time, and she's got to go back to work. She's got to be a mother. She's got to figure out how to be a part of her own recovery, and she's doing our virtual program. We see this kid on the screen. It's not really a breach of HIPAA until they're like 2 years old. That's when they really begin to start understanding a little bit, But we get to watch this kid grow up during our program, just the same way that mom's growing up while she's a part of the program. And so we got to see this kid start smiling. We got to see mom become the woman that she desired to be, to become a productive citizen of society again. And so that's when it really clicked for me that telehealth, virtual care was the future, right? That it was the opportunity to, what's been talked about since long before I was alive, was meeting a patient exactly where they are.
That's right.
And the reality is that this truly is the capability to do that. The intimacy of someone letting you into their home, right? I'm a firm believer that face-to-face does not mean skin-to-skin anymore, right? I feel like I've met hundreds and thousands of people via a screen on Zoom and never met them in person. And I think that changed 2019, 2020 when we all had to shift the way that we were living. So I got plenty of other stories, but I'll hold those. I'll tell you later if you guys want to talk about it.
I just want to add something to one of the things that Riley mentioned is actually the data shows 46% of those who need care travel more than 1 hour each way to receive the care. Think about that, 46%. So that's a barrier to care in of itself. Time, money, transportation, it's a barrier. The other thing I would say about, what has virtual care enabled that we weren't able to do before. So one of the big problems we have in this industry is that we are dealing with a chronic condition in nature. Any sort of mental health, behavioral health issue. And we're working really hard to solve that problem in a limited time frame inside of a residential treatment environment, an acute care environment, maybe a PHP, IOP environment. So there's always a start point and an end point to that episode of care. What's exciting about virtual care, and you can get reimbursed for this, is you have the ability through virtual platforms and virtual care to provide continuing care. Now, why this is so important is because we're looking to drive outcomes now, right? I had just having a conversation with Jacob, and he was telling me about, it's the only industry I know where you can get paid for something that doesn't actually work, right? And so, our success rate in the industry, what is it? What has it been, 30%? What do you think it's been, Riley?
It's
historically.
In the high 20s.
Yeah. So if you want to improve outcomes, you must first improve the care. And so the care is improved by providing chronic care support for a chronic condition. That's the promise in virtual care. So we provide, when people discharge, a part of their discharge plan is they have someone who's working with them ongoing virtually through continuing care. And the outcomes are remarkably improved when you're providing continuing support for somebody who's discharging out of a very structured environment, right? They're leaving an environment that's organized, structured, has a daily schedule, back to an environment in their community that is disorganized, lacking structure, chaotic, full of temptation, triggers. So we, through virtual care, can answer that need, can meet that need. We actually see data in our outcomes data, PHQ-9, GAD-7, the other instruments that we're using, Personal Wellbeing Index. We see that about 30 days after discharge from our program, regardless of any level, 30 to 60 days, anxiety starts to increase. Oh, guess what? One of the things, worrying behavior increases. Sleep patterns start to be impacted negatively. So we don't just look at the instrument, we look at the domains within the instrument, and that guides our care, and that guides our support of the individual. It's very individualistic.
Sure. It's all very interesting. And the stories are wonderful, and I also want to get to the statistics, but let me switch real quickly to legislative stuff, right? So we recently heard U.S. Department of Health and Human Services had said, I believe, that they were going to not revoke, but turn back some of the lenient changes they made during COVID. COVID obviously changed and sprouted telehealth, or at least grew it quite a bit. What are those changes? What's going to happen, and how's that going to affect your world?
Yeah, I can speak to that. So in 2008, the Ryan-Hyde Act was passed, and so that was in regards to a kid that 18 years old, honor student, doing phenomenal in life, ordered prescription drugs online from a doctor he'd never seen. And as a way to combat that transition to being able to have access to anything you want because you can go to a website and get it, was that there was a requirement put into place that required doctors to see a patient in person at least one time before they could prescribe narcotics, scheduled medications. And from a Medicaid perspective, there's a follow-up annual visit. It just depends on the commercial carrier on what they require. But on January 31st, 2020, the DEA and DHHS lifted that in-person requirement and allowed people to have access to life-saving medications, is what it came down to. And so with that, late February, DEA came out and said, hey, we're getting rid of this, and then opened it up to comments. 38,000 and some change comments from providers, specifically medical, psychiatrists, nurse practitioners, business owners of practices, things of that nature. 38,000 comments because people were freaking out. What are we going to do? We've been seeing all these people virtually. We don't have the space. We don't have the staff. We don't have this. We don't have that. So the DEA decided to listen, which was really cool, right? Our voices can make change, I think, is what comes from that. And so they paused it. So until November of this year, the in-person requirement is still lifted. And then if a doctor has seen a patient prior to November of this year, they can continue until November of 2024. So they've added 6 months and then another year on top of that if you've already seen a patient. And what we're expecting from the DEA and DHHS is to really get some clarity on what direction they'd like to go. Because when they first announced it, it was just, hey, we're getting rid of this, good luck, figure it out. And they realized that wasn't a good idea. So the hope is that we're going to get some clarity on what exactly that should look like. Is there an opportunity for providers to be able to stand up and fill out an application to solely do telehealth and not see a patient online? There needs to be clarity on can a associate of that prescribing doctor see the patient in person because they live closer, that sort of thing. So we're going to have more conversations about it, but it looks like there's going to be change that allows us to continue living in this world.
Good. Michael?
Yeah, well said.
Beautiful.
Yeah, I think the belief is that the DEA is going to be in support of the virtual delivery of care for controlled medications. I do think there will be additional regulations to avoid the abuses that many of us have seen recently through the the emergence of some of these large virtual care platforms. So we will see additional compliance requirements, but I do believe, as Riley has said, that the DEA is clearly leaning toward figuring out a way responsibly to deliver care virtually, a responsible way to do that.
Great. So I'm going to save the statistical questions for the end, but I'm going to get to some business model questions, right? So I've got a treatment center and I want to implement virtual care, right? Some sort of telehealth. How do you really establish one that's not only going to maximize profits for your stakeholders and so forth, but also engage that patient, retain them, keep them, make sure that they're getting better outcomes and getting treated? And what have your experiences been about? Do you have any of those numbers? Like, is it easy to keep them, or is the outcome just as good? Sure. What's the efficiency? Does it save you a ton, et cetera? I would imagine it does, but give us some details in your experiences.
Yeah, I mean, for me, for Recovery Unplugged, the objective was, in my mind, burnout is a huge deal in the behavioral health space. Turnover is exponential, typically, no matter where you go. So I wanted to find a way to become the Uber for therapists was my objective. And so what I mean by that is I wanted clinicians to be able to pick work up if they wanted it. I wanted them to be able to lay it down if it wasn't something that they wanted to do. And that's been something that's worked phenomenally well for us. So at this current moment, we've got 37 clinicians that work for us on a per diem basis, and I have never had anyone that has started with us in that capacity leave. I've only ever had to let somebody go. And so what I mean by that is there's zero turnover in that space at this point in time, which is phenomenal, right? Because we all know how expensive those job posting sites have been. Then, you know, for us, what our data shows us is that virtual care and in-person, so I can compare IOP to IOP at this point in time, right? Virtual care is right in line from a completion perspective as in-person IOP, and is right in line from an attendance perspective as in-person IOP. So that's around the 60% mark that we're seeing completions. And then attendance, it varies between 18 and 22% of quote-unquote no-shows, if you will. But that's right in line with what you're getting for in-person care at the same time. So I had a fear whenever we stepped into this space a little over 2 years ago that you know, people would get bored on the screen. People would, I mean, I wouldn't do well sitting in front of a screen for 3 hours, right? Like that's just how I operate. But if there's something that engages, I can watch a movie, right? I can do things that I enjoy. And so the objective in that space was for us to take Recovery Unplugged, put it through a computer screen, just literally that. And so we've integrated live music into the program. We do the same groups that we do in person, online, and it's a full experience. So that engagement piece is the most critical driver, in my opinion. Those constant contacts with the team, the people that are a part of that patient's team is the most critical aspect, in my opinion. And that's why we see the outcomes that we're seeing, because they are remote. They may live in Kingston Springs, Tennessee, which doesn't really have anything in it, right? And they may get bored, but they've got somebody reaching out to them every single day, trying to connect in some way, shape, or form. And it's been a really, really cool experience to watch people be able to get well through this platform. And I was excited that it worked because it was just an idea, and it sounds like what happened for you too, you know.
Oh, the best things happen by accident, you know. It's I would, you know, I would encourage everybody to think of this, you know, as a way to innovate and expand your care, expand your revenue channels as well. You know, telehealth has been around for a long time. It's not like a new idea. Telehealth literally was get help on a telephone. That was where telehealth started in the 70s. And so it's not something new. It's something that's old, that's new again. But I would say, you know, begin thinking of different ways of adding telehealth, whether it's through a virtual PHP, IOP. That's a great way. Another way is just, you know, provide outpatient services through the virtual platform, and you can be reimbursed for that. And if you're focused on demonstrating outcomes, there's no greater tool to help you with that than through telehealth and virtual platforms. I will also tell you, if you're you're getting inquiries in the admissions room, and they're not quite ready to come and admit. They're not ready to, you know, to make that leap and come into a residential environment. You know, start offering them virtual care to incubate them, support them, meet them where they're at. They may never need residential care, but at some point, there's going to be a certain percentage that do. And so start thinking that way. The other thing is on the continuing care side of things is, you know, you also can expand your payer mix through in-network contracts. We've got an in-network contract. We had one of the first in-network contracts for continuing care through Aetna. So I advise you to go and speak to Aetna. Aetna is very much in support of continuing care. And obviously, those of you that are in the Medicaid space or aren't in the Medicaid space, a lot of the money that you've heard that's come through the government in terms of the multi-billion dollars of funding that's been earmarked for mental health and substance use disorder issues is going to be channeled through Medicaid. And so it's a big amount of funding, and there's a great opportunity. Most of those in California are carrying a Medi-Cal policy. They're not carrying a PHP or out-of-network or a HMO policy. So we're gearing up. We just got a statewide contract for Medicaid in California to provide telehealth throughout the state.
That's great. So last business model follow-up, and then some stats and some future. But on that note, what are the risks or concerns? Or so when I think about it, right, I'm like, you mentioned keeping clinicians engaged because it's a little easier, so fixing this labor force we've currently got, that's fantastic. But I would still think, what about internet bandwidth, connectivity issues, or maybe the elderly, or legal and compliance stuff? Like, what are the risks, the concerns? What are those things that you had to overcome that go through my head when I think about, hey, I'm going to employ a virtual health?
There's a lot. There's a lot. There's a lot. It's not super complex. Obviously, HIPAA is something you have to be very mindful of and compliant with end to end. And so making sure that if you have a technology solution, such as CoView, that's in the room here, they're a great solution. I'd encourage you to talk to them. But you're looking for a partner that's HIPAA compliant. Zoom is HIPAA compliant. There are plenty of platforms out there, as my phone is ringing, that are HIPAA compliant, but you have to have a BAA in place. The other thing is the workforce. And one of the things that perplexed me as I came into the behavioral health care industry 8 years ago, I thought that all care was created equal. I thought that all providers, all therapists, all case managers, all nurses were going to do great at providing care. And boy, was I mistaken. I was really ignorant. And I had to learn quickly about why is it one provider does a better job than another. And so I've been on this quest of discovery. And so we have a chief scientific officer who was formerly the head of the doctoral school of clinical psychology for Azusa Pacific University. And when I met him, I said, there's this issue I'm trying to struggle with, because when people ask me, why does our treatment center perform better than others, I would say, because we care more. And it didn't sound very legitimate. It sounded, very unsophisticated, unprofessional to say that. And he said, well, actually, there is a ton of science around that. It's called the Therapeutic Alliance. It used to be called bedside manner, right? Anybody remember the term bedside manner? So there's this science around it, as it turns out. And so we, through putting together a research team, we looked at all of the science and all the data, all the publications around what is that thing? What is the Therapeutic Alliance? The Therapeutic Alliance has a 4x impact on positive outcomes. So we actually put together an assessment that we have all of our providers take, and it measures somebody's ability, it predicts a provider's ability to actually deliver in the Therapeutic Alliance, to establish the Therapeutic Alliance and maintain the Therapeutic Alliance. We validate that through the SAI, Strategic Alliance Inventory, throughout the care journey, and get the client's feedback. So our results are, out of a 5.0 Likert score, over time, we're achieving a 4.6 result, about 92% score. That's about 15% above the norm. So the other thing I would say, only 38% of those that we give the assessment to actually pass. And it's a pass or fail for us to hire. So in the virtual realm, that Therapeutic Alliance, that ability to convey it, that ability to, because it's a flat environment, right? It's a flat screen. You don't have the multi-dimensional, sort of experience as a care provider or a care recipient. So you have to be really intentional, and you have to show up the right way. Eye contact, inflectuation of voice, enthusiasm. You know, the clinical approach tends to be insipid. I say we have to move this insipid approach to a more inspired approach that gets people connected. So using that therapeutic alliance and the techniques and having the right stuff to convey that therapeutic alliance is critical, especially in the virtual realm, even more so.
No, I totally agree. I hire people, first and foremost. Recovery Unplugged does, and that's what makes us great, exactly what you're talking about. And through a screen, there's not a true way to be able to, delineate exactly how much of your energy is diminished through a screen, but I'm a firm believer it's somewhere between 50 and 75%. So if I got somebody that loves to, sit and meander around, and you guys probably all would have walked out the room by now if this is how I operated, right? I want somebody that's gonna come through the screen.
That's right.
That's what it has to look like, right? They have to deliver on a consistent basis. And so I do that, I say that just to, kind of paint a picture of what that individual has to look like. But from a HIPAA perspective, one of my favorite sayings, Einstein said, make it simple, not simpler. And so if you're able to do that in the virtual space, you can really allow anyone and everyone to access care. And so for us, it's as simple as, we need your email, we get their email, we send them a link. From there, they fill out a couple of documents, bada bing, bada boom, they're in a group that night. Nice. So that was a big challenge. It was a lift to get it to be that simple, but we were able to get it done. And then HIPAA-wise, like I said, until somebody's 2 years old, they're not really a barrier for you. But what HIPAA says is you have to make sure you're treating the person that you're supposed to treat. So we have a picture for every single patient that we verify whenever they step into group. And then from there, it's really just adhering to there being nobody else in the room with you. You're not in a public setting. Nobody else can hear, that type of thing. But outside of that, it's, you set those standards on the front end with the patient, really set the expectation, and then moving forward, you just refer back to it, and it's worked pretty well so far.
I love that example you just gave.
Thank you.
Because although it, super, you got to the point that I love that because it's super important about engagement. Because how do you keep people engaged and vested in their care? And if you're just, if you're flat, if you're not giving them something that's compelling to interact with, they're not going to want to come back. So that point should not be underscored. Super important.
Thank you. I want to leave time for questions. So let me just ask one more quick one. Maybe you can each give a minute or two. Sure. Maybe you can employ some of the statistics. So I've heard it's pretty much this is effective. The stats you gave me are impressive. I was curious about that. I'd be curious how much more efficient it is. So it's great about the labor force, now you can keep clinicians, but I'm thinking, couldn't I scale much quicker that way, virtually? And along those lines, if we think this is here to stay, that would be my question. Is it short-term fix, or is this long-term? I think you're gonna both say it's here to stay. Then how is I guess what are your tips or insights? Like how is the best way to implement that, put it into my program, and address all those issues that you've been through?
Yeah, so is it scalable? Absolutely. You don't need a brick and mortar. You never run out of beds. You never run out of group rooms. It's the most efficient way to stand up a program. Right. In my experience, it takes a lot less time than building out an entire facility, right? And then with that, I'm a firm believer that it's a long-term solution for behavioral health care, both substance use and mental health. And for us, we really like to make decisions based on data, similar to what you're referring to, Michael. And we've treated in the past almost 2 years in the virtual space 2,400 individuals. And out of those 2,400 individuals, every single one of them, we do a survey afterwards, the NPS survey, and so NPS score across the board out of those 2,400 patients, an 85. NPS scores typically range in the 40s, so we're not doing too bad there. Our goal's 90, so I want to be at 90. I'm not there yet. But then the two questions that are most important for me are, do you feel prepared to continue your recovery journey? 100% out of almost 2,500 patients. Wow. And then the other question, goodness, this is the one I wanted to hit on. I forgot it. Of course. You go.
Okay.
Feel free
you'll
to.
remember. I think one of the data points that we track is how does virtual care compare to traditional in-person care from a no-show rate, right? Yeah. So do you guys know what the average no-show rate is for standard therapist appointments? Anybody?
40?
No, 19% nationally. So 19%. And so our no-show rate over time is 8%. Pretty good, right? So is it here to stay? Is it effective? Yeah. Is it sustainable? If you don't have an active participant, it's not sustainable. So with an 8%, this is therapist to client no-show rate. That speaks pretty strongly. Yeah. So yeah.
It's huge. Any last thoughts or tips and points?
The question that I forgot Michael had note cards. I wasn't nearly as prepared. But it was, did you feel that you received a high quality of care? 100% of 2,400 plus clients said yes. So that's something that I like to be really, really proud of.
Yeah, I'm sure. We're about out of time, so let's see if anyone in the audience has any questions for you guys. One in the back, end here.
Yeah, my question is, how did you get past some of the licensing issues across state lines? I work with a residential treatment program, and there's an absence on the continuum of care, and they want to offer some type of PHP program remotely, but there's issues with license. So could you speak to telehealth and the license issues across state lines?
Yeah, I mean, the short answer is you got to be licensed in a state to provide care. That's the simplest answer I can give you. I've tried to find a workaround. I haven't found it yet. If I do, I'll definitely let you know. But that's the simplest solution, right? Go obtain a PHP license in the state that you're looking to be able to treat that patient in. There's no workaround at this point in time because there's no compact licensure for not only clinicians but from a level of care perspective. So there's no hop, skip, jump right to solution, unfortunately.
A couple of things I would say that maybe a little nuanced inside of that is, anybody familiar with SIPAC? So there's something called SIPAC if you have a psychologist on staff, a licensed psychologist. There are about 36 states that have opted into the SIPAC. So you can, under that provision, you can practice across state lines for psychotherapy. The other thing is subclinically, paraprofessionally, peer support. There are certifications state by state, but there are many states that basically do not require you to have a certification. So for life coaching, there is no real certification, and you can get reimbursed for that as well. So that's a way to practice across state lines, but you have to be 100% compliant without exception.
Gotcha. One last one here, and then you guys can talk afterward if there's any more.
Thank you. Hi, Jeff Rubin, Hub International Insurance. I just had a question regarding staffing. You mentioned bedside manner and transferring it virtually. I was wondering, with the staffing issues, do the doctors that you're working with find that to be a challenge, and are they staying, on the telehealth side or going back to more traditional environments?
So at Recovery Unplugged, we utilize we have an integrated care model, and what I mean by that is Recovery Unplugged provides the IOP piece, and then we have Karma Health, which is an addiction services outpatient group that does the psychiatric services as well as medication management. And so we bring those two together to then provide the medical services for the patients. And they love the capability to be able to see, an additional X amount of patients per month from a telehealth perspective. We do also utilize telehealth from a in-person PHP and IOP perspective to be able to see patients more consistently based on what the physician sees as a fit for that patient, not just to be able to allow patients to be seen. I've seen it to be something that clinicians find as an opportunity for themselves, not only for the patient, in a big way. That's been my experience.
Yeah, I would agree with that. I think there is a bias post-COVID for practitioners, primary care providers to work virtually. That's the preference. Whether or not they all can show up the right way is another issue. And so you have to have quality assurance measures and standards. We rate, like we have the clients give us feedback on every discipline in our integrated care model, and we can see how each provider is rated by that client.
Nice, yeah. Thank you guys very much. Maybe a hand for Riley and Michael. Thank you guys.
Good job, man.